welcome everybody to a PCNA Wednesday webinar. My name is Sarah Begley and I am part of the PCNA steering committee. So before we get going, we'd like to acknowledge the traditional owners of the land. I'm currently joining you from the Larrakia land, the Larrakia people. And we'd like to recognise their continuing connection to land, waters and culture. And I pay my respects to the elders past and present. So these sessions from PCNA are designed to support nurses and the broader health workforce by providing access to contemporary learning and practical insights and conversations led by palliative care is on boundaries. And we will cover how we navigate boundaries in a field that really is set up for us to lean in rather than step back. And we're going to explore with Jess and Holly, and I'll introduce them in a minute, about how we do that well and safely in palliative care. Before we begin, I'd just like to do some housekeeping. We would like you to use the chat function if you can, and we're using Teams for the first time this month, so you can. It's actually called Q&A. What we ask you to do is mute yourself, put your camera on if you can, and ask questions in the chat, because today's topic is really about interaction, and everyone will have a different perspective on what Holly and Jess explore, and your perspectives will be something that's very useful to the conversation. We will have an initial presentation from Holly, and then we will have Q&A where Jess and Holly will have a conversation. This session is being recorded, and for those who have registered, they can watch it afterwards. And we would really appreciate your feedback, and we will pop the Q&A, the survey in the Q&A at the end of the session. So I'm delighted to introduce you to our presenters today, who are Jessica Brown and Holly Pitt. Now, Jessica is the manager of the Monash Health Palliative Care Consultancy Service. Give us a wave, Jess. And Holly Pitt, who is the nurse unit manager of the palliative care unit and ward at Peter MacCallum Hospital. Thank you both of you for joining us. So please join with me in welcoming Holly and Jess. And Holly is going to speak to us first with a brief refresher and conversation starter. So Thank you both of you for being here.
Thank you, Sarah. So I sort of second what you said. This is a really interesting topic where, hang on, if I can share my screen, let me just, is that working for you guys? Can you see it?
Yep.
Okay, I just need to make you a little bit smaller so I can see it. Hang on. Bear with me. Hang on, I'll stop sharing for a second. Sorry, guys, it wouldn't be a webinar without some glitch.
While we're waiting, Holly, it's a very impressive turnout, 25 people live. It's obviously a topic that really touches some relevance to all of us, no matter where.
And I think it doesn't matter where you are in your career. I think when you said refresh, I think that's the key thing. This is really a refresh, and it's also for really early career nurses to sort of start to think about boundaries.
That going, Holly.
Yeah.
I might ask Jess a question. Jess, are you all right with that? You're unmuted. So I'm going to ask you, how has your journey with professional boundaries changed over time? And has there been a moment in your career where you feel like you've stepped outside your boundaries, and how'd that feel? We'll get the conversation started while we're waiting for Holly.
Absolutely. I think that's a good idea. Take Holly off the spotlight for a moment. I think my journey started probably even before I became a nurse. When I was at uni, I worked in a what we called low-level respite nursing home. As a personal carer, I was the one in charge on the weekend. Wouldn't happen now, did happen back then. I was administering medications and doing the whole thing. And I think even then, as a quite young person starting to learn about boundaries. You know, you've got a whole facility full of aged care residents, some of who are quite lonely, and navigating your own boundaries then was very interesting as somebody who was, you know, 19 or 20, and then going through working on the ward, working through ED, right up into working in the community and palliative care. I think it's been a different journey. We can talk about that throughout the session, because I think in each setting there's been different boundaries. They've looked a little bit different, and the nature of the work has been different as well. So I think every time I've started in a new setting, there's been a new lot of boundaries to consider, and that's challenging. And I could talk forever, but I'll check in with Holly and see how Holly's going with her presentation.
I think, why do we have boundaries? I've just, like I said, we'll fly through these really quickly, but the importance of boundaries are that they are there around our legal obligations. They support ethical and moral obligations in nursing, and essentially they provide safety for all involved. And it's not just patients and families, it's for ourselves as staff. So I'm going to talk a little bit about boundaries with patients, carers and families, but also within our own team, and the personal impact that occurs when we don't have boundaries or when they start to blur, and what that can look like in terms of burnout. We want longevity in our career. We've just recently seen through COVID quite an exodus of really senior experienced nurses, and we want to sort of really invest in our early career nurses and make sure that boundaries is something that's, you know, forefront in our minds when we're starting nursing. Thanks, James. So we have personal boundaries. You can actually just flick through to the next one. We have our personal boundaries. I think if we reflect on what we do in our everyday life, we do set boundaries. We set them in space when we're in public transport. We know where to sit or how close to stand to people in a queue. We know what respectful tone is. We know how to respect someone's time, their efforts. There's respectful boundaries around money and expectations on workload. Volunteering, we have them in language, you know, whether it's humour, swearing, slurs. We have them around gossip, privacy. We all know an oversharer. We all know someone who wants to share the intimate details of their weekend in the staff room that no one wants to hear, or someone desperately wants to hear because they want to share it again. So we set really personal boundaries. We have them with our families. We have, you know, everyone jokes about the classic mother-in-law and that lack of boundary setting with children and grandchildren. So we can kind of reflect as nurses and go, well, what do we use? We use communication, and we build confidence through communicating those boundaries in our personal life. And I think there's this assumption that we carry all that ability to set boundaries and we carry all that sort of thought process around boundaries into our professional life. And I don't feel like that's always the case. As Sarah sort of alluded to, we're in a profession where we feel like we need to really lean in and do more and give more and have this really broad lens of care. And so sometimes these personal boundaries get left behind. Next one with James. So, you know, when we talk about burnout and we talk about boundaries, we have to think about empathy and just how much we really have to give our patients. You can pop to the next slide. So professional boundaries, we have what our organisation sets for us. We have the really clear things that come in our guidelines. They're in our policies and codes of conduct. And they're kind of given to you in your onboarding when you think about data and privacy and your security stuff that we need to do. OH&S, OVA, there's really clear boundaries in how we protect. You've seen all the media things about healthcare workers and boundaries and what people can and can't say to us and do. So that's sort of set by the organisation itself. And some of those have the obvious stuff, and we know that around social media, giving out mobile phones, sharing other people's, you know, mobile phone for contact, dating, money, gifts. There's all the kind of stuff that we think of all the time. But in my experience, it's the subtle blurred boundaries. It's the little boundaries that we let go all the time. And they're not necessarily, as an individual boundary, going to be a big issue, but it's when over a career or throughout your workplace, if there's multiple blurred boundaries, that's when we start to have impact on our, you know, on our self-care and burnout. Thank you. So how does it happen? And this, again, I don't think it is about being an early career nurse or an experienced nurse. As Jess alluded to, it can change from the dynamic of your team. It changes from organisation to organisation and job to job. So this is just a really quick overview of some of the ways that we can kind of lose sight of that boundary without realising. We want to identify and we want to be relatable. So we want to engage and be curious. And we always talk about that, be curious with our patients and engage in that conversation. But we do try and relate through similar things. And that can be age, it can be your culture. By culture, I mean music, art, lifestyle, ethnicity, in any way. And we attempt to connect and relate. And sometimes that can blur the boundaries. An example of that, like if you think of music, it could be, you know, my patient's got a Chili Peppers t-shirt on and I walk in and I'm like, oh my God, that's my favorite band. I love Chili Peppers. I'm going to the gig on Saturday night at the corner. And they're like, I'm going to that gig in the corner on Saturday night. I'm going to see you there. Boom. I'm now in a situation where I'm like, am I comfortable having a dance and a drink on the dance floor? Are they comfortable? You know, it goes both ways. I've now breached a boundary, not just for myself, but that patient might want to be at that gig and not have their nurse that reminds them of their illness or trajectory or prognosis or whatever. And I might like to go there and be who I am when I'm not professional and I want to be able to have a good time. So really innocent, but all of a sudden I'm in a situation I can't control. And the same with shared experiences or groups. And I know a lot of us come from small, I live in a small regional town and I've done community nursing in that space. It's really challenging when you share social circles. You come from a small town. It can even happen in the city where it might be you're chatting and, you know, your patient says, what are you up to on the weekend? And you're like, oh, I spend my Saturday mornings at this great little bakery on the corner of Sydney Road in Brunswick because it's my favourite place. And they go, I'm going to come and check that out. I'm actually in Brunswick. You know, it's just so easy to blur. And then you're thinking, oh, I'm going to sit there and have my coffee and now the patient's going to come in and do I offer them a seat to sit with me and do I have to give up my Saturday mornings? It can be sporting clubs where you see someone in a sporting top and you relate and say, yeah, my son's in the under 10s. Oh, my son plays under 8s for Coburg as well. You know, again, perfectly innocent, and it might be nothing more than a wave over the oval on a Sunday morning, but it could also be you find yourself with a patient then coming up and saying, hey, I just thought I'd catch you because I've run out of scripts. Do you know who I call? Or is there any chance you saw my blood results on Friday because I can't get into my health hub or whatever? Or here's a rash, you know. And so you're not at work, you're with your children, you're with your family, and you're now kind of caught in this blurred line of professional and personal space. Perfectly innocent, but really easy to fall into. And the other example I've given is what I call like the lonely patient or the vulnerable patient. We're really giving in our profession and we want to go over and above. I hear that phrase all the time, that nurses go over and above. And it's not always in the best interests of probably the patient, but not always in the best interest of, again, that longevity in our careers of always giving a bit more. That can look like, you know,
Beautiful.
doing the grocery shopping for someone on a weekend, getting
X-ray is not different, you know, so we will see it.
Sorry, guys. Are you able to mute?
Oh my God.
Someone is off mute.
Peter. Thank
Thank you. So yeah, it could just be an example of, you know, picking up cards or doing a little shopping or getting a little bit extra for a patient. And we think we're fostering connection, but actually we're stepping a little bit outside of our role. And again, I've seen an example where someone had to relinquish their cat, was not on social media. The nurse very kindly lent in and went, I'm on Facebook, I'm going to put a post up. And before she knew it, she was really heavily involved in having to go to the house to meet someone to get the cat. You know, there's a breach now of privacy and getting house keys. Really innocent gesture, but led to really blurred boundaries. So there's certainly, if you don't mind going to the next slide, James. The question I get all the time is, well, what is wrong with that? Why can't we do all of these things? And, you know, I can't answer that for you. I don't think anyone here has that answer for what's right for each individual. But I think there's some really great tools to think about when we might be blurring the boundaries and when we might be overstepping. So two things that I like to really think of are, can I do this for everybody? Is it just a great flag for me to go, well, can I do a grocery shop for every one of my patients? Can I stop and look up results or share, information with everybody? Can I give an extra half an hour on my shift to all my patients? Probably not. So is it sustainable? And then is it equitable? Would be my other thing. The other question I think is really good to ask is, would I share this openly with everyone in my team? So, am I comfortable saying, oh, hey, I bumped into Sarah at a gig on Saturday night. We ended up having a drink and having a dance at the Chili Peppers because we both love that band. If there's part of me that goes, oh, maybe not everyone in the team's going to be okay with that, it's a moment to go, maybe I need to talk to someone about that and go, where's your line on this? Because I'm a little bit blurred. It's not, again, there's no ill intent. There's nothing malicious with what we're doing. These aren't big boundary breaks that you think of when you think of, breach of privacy or things like that. These are really subtle ones. And so talking to your team is a really great way to gauge where you sit. And often I hear, well, I don't want to be disconnected and I don't want to be cold in my nursing. I don't think that's the case. I think we absolutely can go over and above, and we can be empathetic and have really wonderful, safe boundaries in place that, in my opinion, actually fosters great connection. So thinking back to Chili Peppers, it's all about the confidence in the communication we have, like we do in our personal life. So I could say to Sarah, wow, we both love the Chili Peppers. We're both going to that gig. And then I can say, do you know what? Just given it is outside of work, I probably won't see you at the gig. But next time you're admitted, let's chat about what you thought about the gig, and I'll tell you what I thought, and we can compare notes. You can, and again, with the soccer, you might say, if I see you on a Sunday game, please don't be offended if I'm just in my own headspace, because when I'm there, I'm really focused on my kids and it's a really important family time for me. It's still acknowledging, it's not dismissive, it's not disconnecting, but it's just setting a boundary, which again, I think provides a sense of relief probably for our patients, that we're also not going to be presenting in their personal world and taking their illness with us a little bit and being a reminder for them. So it can go both ways. Thank you, James. And yeah, you can go to the next one as well. So I guess within your team, what we think about, we've got the patient and family boundaries, but then on top of that, we're thinking about within our own organisation, our own team, boundaries around patient allocations, rostering, oversharing in the staff room, being spoken over or unheard, just workload. And again, that common stuff, language, jokes, personal space. So the same confidence and that same boundary setting and communication skill set's really important to be able to say, hey, I don't mind doing late earlies, but not consecutive. I don't mind having that patient, but can I not have them 5 days in a row? I appreciate that's your style of humour, but just to be mindful, it's not mine. I'm probably not the right audience for you. Doesn't mean we can't have a laugh, but you're just not going to get a laugh from me with that style. Or I love how loud and confident you are to share. I'm actually really private. So probably not the best person to share with. It's not rude. It's not offensive. It's just a beautiful way to set some boundaries. The reason we do that is all about self-care. It's all about longevity. We don't want to carry the weight of our nursing and our relationships right through our career and end up burning out and leaving our workplace early, leaving our careers, and moving on to something else. So the other component with palliative care, I think, that is a little bit different to just general nursing is that tapping out aspect. We are dealing with people at end of life, and it is more vulnerable and it is more heightened in emotion. It's a complex cohort of patients. Having the ability to tap out. So that would be different for everyone. It might be that the patient is just too relatable. So my team know I have a son who survived childhood cancer, and he's now a young, stinky adult in his early 20s. But when I have young adults come through who have relapsed, my team know already. I'm like, I am of no support to that family. I have got nothing left. I'm empty on empathy and it's all about me. And so I tap out. And my team already know that. I already know my team member might have a sister going through treatment for breast cancer. I'm not going to allocate her patients that are of similar, disease trajectory or just too relatable. So we all have this wonderful communication where we set boundaries and we support each other in maintaining them and saying, hey, we need to tap out on that. So all of that is really around, if you've got good boundaries with patients and families, you've got good boundaries in terms of your team, and then it's boundaries around, is this patient too close to home? It could be a family member that you're caring for. It could be just too close to lived experience. So it's finding your voice and setting those boundaries nice and early. Thanks, James. I think we all know probably in nursing what burnout looks like, but it is, we do run on empty. We do become indifferent. So that whole concept of, but not having boundaries means I'm going over and above and giving more to our patients. We need to think about sustainability over the length of your career. If we burn out, we can't become indifferent and we run on empty, and we actually we'll be giving less than what we would. Thanks, James. So really my message around boundaries is keep check, always sort of, you can be patient focused, you can be really supportive, but keep conversations about them. Avoid that pitfall of inserting yourself into the conversation and blurring the boundaries. Resist the overshare. And if in doubt, I think, nurses are honest. Talk to your team and really follow that sort of key of, can I do this for everyone? How would I feel if I did do this for everyone? How much can I sort of take? And support your colleagues, really mentor. If you're good at setting boundaries, mentor those junior nurses coming through. When people come to you and say, I think I've blurred the boundary, we don't want to be, critical. We want to go, that's okay, we've all been there. These are some great tips. We want a supportive culture so that we all kind of become really confident and have those communication tools to manage them. So I think that's it. I hope I haven't gone too long on that, Sarah, but
No, you haven't.
throw to questions now.
Well, what we might do is we will, while Jess, Holly and I are I'm going to ask Jess and Holly some questions. And while we are talking, those that are with us, if you can put some questions in the chat, if you've got them, we will add them. I'll put them to Jess and to Holly. And also everyone who registered did a really good job of putting in what you will learn into that registration. So I will ask some of those questions. I just wanted to say, I loved your example about the gig, Holly, because I think that articulates so clearly how this starts with the best of intentions. That it's all about rapport building, which really is the core skill as a palliative care nurse, building that trust.
Yeah.
And it's just, it kind of leaves the station and then it's gone. And then, yeah, so I love that example. And I also, my take homes there were the questions to check yourself. Would I share this with my team? And would I do this for everyone? Two really good questions. So then my question for you, Jess, is you told us a little bit about where you started in your career. My question for you is, have you, and this is a bit of a bold one, have you ever overstepped a boundary? And how did that feel? What happened?
I think possibly emotionally and on the inside. How again, this is a little bit bold, but the comparison of, I didn't have an affair, but it was like that emotional connection. Like I possibly felt myself connected to a patient. And as Holly said, you don't know who's going to trigger you. You don't know why somebody's going to trigger you. But somebody sits with you. And I was drawn to that patient, and instead of recognizing that early, because when you do feel connected, you want to provide care and you want to continue to care for that person and their family. So I probably did that too much and then took that with me more than I might have if I had have recognised that earlier and said, you know, this was a patient in the community. Yeah, that's probably been a number that stick with you. But had I have really reflected on that, and I think that's a big part of it, had I reflected on how I felt at the end of each of those, and the fact that I continued to think about that patient and her family, I may have not had that impact when our care stopped, when she died. So yeah, that's probably an interesting one. I don't know that I've, you know, had anything concrete, but it's probably been that emotional boundary that I've crossed within myself that perhaps I haven't reflected on and caught. And I think that's really, really hard in palliative care. You know, I think we're a compassionate bunch, and we want to provide care. And the more connected we feel, the more that compassion comes out. So.
Yeah, and I guess what you're saying, Jess, is that very much boundaries are in some ways about knowing yourself, aren't they?
Yeah.
And knowing, as Holly's example about her son, right? Knowing what your past experiences have been, knowing yourself, being reflective enough to go, right, well, there's a response here from me that's maybe outside of what's helpful for the patient.
Yeah.
I guess, Holly, my question for you, kind of related to that, is I guess if we talk about boundaries as a spectrum, what would be on either side of the spectrum for you? You know, what's okay, and then maybe what's on the other side of that spectrum? Because I guess the point is we all have our own.
Yeah, absolutely.
What's for you? What's on your spectrum?
Probably I also just want to flag something because I just love what you said, Jess, but also around, you know, often we say to caregivers that it's really important to keep that role, you know, that we don't kind of need you to be the nurse, we need you to be the partner or the daughter. And we often use that phrase around maintaining roles. And it's a really good reminder, I think, to us to go, well, if I'm being more of a friend or a fan, you know, acting like a family member or being like a best friend, am I losing sight of my role? And does that then put family or friends in a position where they need to kind of balance it a bit and be more of the nurse or, you know? Yeah. So it's a really good reminder to me to sort of go, hang on a minute, if I'm asking them to maintain their role, I've got to do the same. In terms of boundaries as a spectrum, it's hard. I think it's that old saying, if no one ever gets to you in palliative care, you shouldn't work in it. And if everybody gets to you in palliative care, you shouldn't work in it. So that's kind of, you know, I feel like if you are emotionally invested and impacted by every patient and every outcome and decision, and, you know, there's a lot of cruelty that we see at end of life. It's just a lot of things that are unfair. And if we're unable to disconnect from that to be able to do our jobs, I think that's concerning for our mental health and well-being. And on the other side, if we're coming in very robotic and transactional and tick box in the work we do, then this isn't the job for you either. You know, we're not ICU, we're not machines and buttons and bips and doses. It's much more a philosophy in care. So I think you've got to find where you sit along that spectrum.
Yeah, and I guess that's the tricky bit, isn't it? Is that it's somewhere in the middle, but no one quite knows exactly what that is, and that's different for everyone.
I think you recognise in yourself. I think it's looking for the burnout, the irritability, the feeling a bit overwhelmed, if you're feeling a bit empty, if you're not loving your job, it's thinking about, well, hang on a minute, what is it? Is it the boundaries I have in my team? Is it around the allocations and the rostering and the workload, or is it around my boundaries with my patients and families, and do I need to reassess?
Yeah, I guess related to that, I get we all work in teams, and I've certainly come across circumstances, being in teams where team members, everyone has their different boundaries. And I've had a team member who will be going and giving mechanic recommendations or dropping off extra groceries or fruit tingles for their dry mouth on the weekend. Jess, how do you navigate that when someone else in your team, their boundaries are really quite different from you, or you feel like you need to say something, but you're not sure if you should?
I think it's a really interesting area because I think everything that I've written down, I've sort of written some notes as you guys have been talking along the way, and everything I've written down is it depends. And I think it's palliative care. We live in the grey. Nothing's black and white. And I think I keep coming back to also I've been talking to an amazing person. His name is Jay, and he's doing a presentation at our conference in June, and he's looking at the work that gets done by nurses every single day, moment to moment, when they're having an interaction with patients, but we know it happens with everybody. Managing boundaries, managing what might be culturally appropriate, what might be age appropriate, what might be. And so I think we are doing this every moment that we are with a patient and family. We are navigating boundaries all the time. And I think that it depends on so many patient factors, and it depends on so many clinician factors, that it's almost impossible to have the same boundaries across a whole team. Because I know in my team, I've got one nurse who, will buy a patient's favorite lollies and take them to him. I've got other people in the team who wouldn't even think about doing that. So is it, and that's a very benign example, but I do think that it really depends on the relationship between the clinician and the nurse, and whether or not it remains therapeutic or whether or not it has gone beyond that. And that can be really difficult to determine. I think for me, when I see that, I'm like, okay, well, I trust, she's an advanced practice nurse. I trust her judgment around her therapeutic relationship. What happens with me and what I've seen in teams before is when there starts to be issues amongst the team. So if two nurses feel a connection with the one patient and start to argue over who should visit that patient, that's where we're starting to get issues, and that's where it's starting to become highlighted that there is overstepping of boundaries. So I think it depends on all of us reflecting on our own practice and reflecting on our own how we work with our patients, and whether or not we're doing it in a therapeutic manner or whether or not we're doing it in a personal manner. And that can be very difficult, especially in palliative care, especially in my context of palliative care, where, my nurses are working autonomously. They're not working in that ward environment. Same for community nurses. They're not working in that ward environment where you're seeing the interactions. So there is a high level of trust. And so therefore, it's really an essential thing for us to be able to reflect on our own practice, because no one else is going to call us out on it until it becomes an issue within the team. And by then, it's hard to pick that apart. I don't know if that answers your question, Sarah, but they're the things that are sticking out in my brain.
That's great. Yeah.
I guess I'm going to be even bolder and be like that. You're right. You're right. All of that is true. And it is very much about every situation and every team and every clinician and knowing yourself. But I'm going to be more bold and be like, okay, person in your team is offers to have the patient visits the patient at home, says, hey, you live just around the corner from me. And you go, that really doesn't feel right. That really feels like that's crossing a boundary. What do you do then? How would you approach it, Jess?
So for context, me and my team work in the hospital setting. We work in a consult role. So we're certainly not out in the community where that would be completely normal. But
if they did,
pardon?
If one of your nurses said, hey, I've got your address, I'm gonna come visit you. And it was all amicable. She was like, and the patient was like, sure, we're great. We're gonna be great friends. What would you do?
And I think oftentimes people don't realize that they're crossing that boundary because, again, they're doing it with good intentions. So I imagine that this nurse has come back to the office and we're having a bit of a chat, and my nurse has said, I'm going to go visit patient whoever. I think the first question to put to that nurse is, who are you doing this for? And I think, Holly, I don't know if you said it in your presentation or we've said it in our conversations, why this patient and not all the other patients?
Yeah.
Because this is not our usual practice. So why this patient? What is it about this patient that you're going to do it for? And let's talk about that.
Yeah. And I think natural relationships can form. I think that's okay. We form best friends through sometimes 5 minutes waiting, in the line for the toilet, and all of a sudden you've met your best friend for life. It happens. But then it's around, well, where is your priority? Do you think that this is a personal relationship, that you've got a connection, in which case do you no longer have access to their health records? Do you no longer be allocated that patient? Is it, it's what is your emotional maturity around that, and having all those conversations. And sometimes it's inevitable that people form relationships. They form friendships, or they form intimate relationships. It happens. But I think if it's transparent and it's open, again, if you can't talk about it amongst your peers, then it's a flag. Whereas if you can put it on the table and go, I didn't mean for this to happen. I've been a nurse for 20 years and I've never blurred that boundary, but we get along like a house on fire. So, where do you go from there? Do you not see them in a professional capacity, or do you decide not to see them in a personal capacity? It's tricky.
It is a fascinating area, isn't it? Because every person has a different idea of what is okay and not okay, right?
And in a small town, how do you do that? I mean,
exactly.
When you live in regional or rural areas, you don't have the option. And I think it comes down to strengthening your communication skills. And again, a very senior nurse, you gave a great example, Jess, of like one nurse might buy patient lollies. That can feel really crummy for the nurse who doesn't. So, we've had nurses that are more than happy to take patients out on their break in a wheelchair outside. And then the expectations the next shift, they're like, well, why can't you? The other nurse does it for me, And so the nurse feels obligated, or feels like, I'm not a good nurse because I'm not going over and above, but my boundaries are different. And I think a very senior nurse might have the confidence of communication to say, hey, Jess, I really appreciate you doing that for that patient, but are you aware of the expectation it sets for everyone else? When you do that, could you let them know that this is a one-off thing that you do and not the, something like that. But it's our early career nurses, I think, if you don't have that confidence and that communication skill set, you can just harbour those feelings as they go along and feel a bit resentful, perhaps that good cop, bad cop, that you're not the one buying the lollies.
Yeah, and I loved what you said in your presentation, Holly, about it's about practicing those lines, isn't it? It's like, oh, look, we will see you at the gig, but look, don't be offended if I don't talk to you, because look, blah 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 blah. Like, or if I see you, I'll just wave, and because I'll be focused on my kids. It's okay to have those conversations, isn't it?
Yeah.
So then
we do it in our personal life. We do, yeah.
Yeah, and so Holly, I think we've already kind of touched on this, but I guess one of the questions I have is, how do we determine between actions that are for kindness or, care for the patient, what Jess was saying, therapeutic for the patient, or those that might be meeting your own needs? Where does it, is it another blurry grey answer? Or
Again, it's really tricky because it depends what your needs are too. But I think Jess sort of answered it before, and a little bit in the presentation around, can I do this for everyone? And why this patient? So what is it about this patient and what am I doing it for? And I've had times where I have absolutely gone over and above, and I've reflected and gone, I actually did not want to be in the office. I was feeling quite flat that day, and doing this made me feel really good. And it connected me back to being, what I felt like as a clinical palliative care nurse, for example, when I was on the floor and doing family meetings. So I've had those moments where I've stopped and gone, oh, I've really invested a lot of time in that one particular outcome or patient or family. What was that about? And I've been able to reflect and go, actually, I just needed to do that day. That made me feel really good, but I wouldn't be able to do that every time. And so it was more about where I was that day and what I needed out of the day for that pep in my step, really. And we do things like, we go crazy sometimes. We can pull a wedding out of a hat on the same day. We do end-of-life care smoking ceremonies. We get people home, that they've said on a Friday night, I want to go home tomorrow for the grand final of footy, and you've got oxygen and equipment. You can pull out all the stops. That's not really breaching a boundary, though. That's kind of the workload of it. It's when you kind of emotionally give more that's when I've had to stop and go, I really gave a lot of myself to that one person. I think I needed that perhaps more than they did on that day.
And I just like the way that you talk about it, Holly, because I guess the point is it's not black and white. And what might be a hard no for someone is not necessarily for everyone. And I think that's okay as long as you're reflective, isn't it, really? And I guess this then relates to my next question, which was for Jess. We, as Holly said, we can and we do. We pull out all the stops in palliative care, you know, because we can. And it's kind of what we do. Have you ever found yourself justifying something, maybe crossing a boundary because palliative care is a little bit different? That's a tricky one, Jess.
I think, yes, absolutely. And I think, is it that I'm crossing a boundary because it's palliative care, or is it that the boundaries are different because it's palliative care? And I was reflecting on this earlier, and I was comparing when I worked in ED compared to when I work in palliative care. And we have a little bit of a difference in that we have a time-limited relationship with our patients.
Mm-hmm.
And we know that. Whereas if I was in ED, so treating people with kindness, even if we get into a little bit of a situation where people become a bit emotionally dependent on us because we have potentially crossed a little bit of a boundary, somebody's, bought the patient Maccas on when they've gone to do their home visit a few times, and now that's a bit of an expectation. That is a time limited issue. Whereas when I worked in ED, you would have young people coming in, and maintaining the boundaries was really, really important. And so therefore the boundaries were a lot firmer because this had no limit on it in terms of timeframes. So I think that the boundaries are incredibly different in palliative care for many, many reasons. And then you come to the people that self-select working in palliative care. And as we said, they're a compassionate bunch who want to go above and beyond and love the hustle of getting what needs to be done to make things a little easier for their patients and their families. I don't know that I consider that to be crossing a boundary. I consider that to be the therapeutic work of palliative care, which incorporates compassion. I think the interesting part comes, and I think you alluded to it before, Holly, around setting expectations early. And I think we had somebody, there's many themes that have been presented before we had the webinar. And one of them was managing families after death who want to stay connected. Yeah. And I think that's a really interesting area. And I think, something that I've struggled with is expectations around funerals. And again, different people will have different expectations as clinicians about whether or not they want to go to funerals. And there may be different patients that they feel differently about going to the funeral. We had a circumstance where we had a very young person die, and the family is quite upset that nobody from our service had gone to the funeral. And I found that very confronting because I understand that. But I also understand from the service perspective why that would be the case. But I also understand from other service perspective that wouldn't be the case. So I understand all of the perspectives. But I think what's important is exactly what Holly said, is setting the expectations early in the relationship around what the boundaries are for that setting, in that organisation, in that context. And that also sort of alludes to, there's a question there also about that idea of cultural non-disclosure when families request that you don't tell their loved one any great detail about their diagnosis or their prognosis, even though that person has decision-making capacity. And that does get into blurry lines with boundaries as well. And that's where we have to set the expectation that if our patient asks us questions, we will not lie. We will answer the questions honestly and truthfully. And that oftentimes people do ask us questions, and we will provide that answer, when they ask. So, we're walking this tightrope all the time. And I can't even remember what the question was now, Sarah. I'm sorry. I don't know if I answered it.
That's okay. It's good. What I wanted to pick up on would be, so Holly, what do you think? How would you navigate a situation where a patient's family said, look, I'd really like to stay friends after this, or can we stay connected?
Oh, look, to be honest, I'm quite clear in expectations, and just especially around funerals, in that unfortunately in the work that we do to be able to give our time to the patients we have, we're just not able to get to every funeral. We're not able to get to every service, because then we actually wouldn't be able to do the job that we're doing. So we have to balance that. So, I have been to the odd funeral, but actually that's my personal boundary. And I also just don't have the physical time to, it would be taking away from supporting a team to be delivering palliative care every day. So you've got to, you've got to balance that. And I like the one, Jess, we get it a lot where, please don't tell mum she's got cancer. Please don't tell mum she's dying. And I like to be really curious on that and say, can you tell me what you're worried about? What do you think would happen if mum knew? And often I'd say to them, I think mum already knows. We don't often have to say it. I think she already knows through this is what she's showing us, and this is how she's acting, and this is what we're seeing. And often they're really scared to say anything, and the patient's actually really scared to say anything because they're protecting. So sometimes those curious questions of just unpack it a little bit. And again, absolutely what Jess said, we need to be very clear. We're never going to lie if someone asks the direct question, but actually, what is it about you that you're worried about? Tell me something that you're worried about if mum was to find out she was dying. And often it can be, she'll be distressed, or she'll be panicked, or she'll be frightened, then it's the conversation is, well, how could we support her? And that would be a really natural response, to be frightened. And it just sort of leads into more and more support, really. Sort of just breaking down what is the barrier.
I have a question for you both, and then I'll jump into the chat because there's a couple of questions in the chat. But I reckon a common one for palliative care nurses, and I know Jess and I've discussed this many times, is that you become, being a palliative care nurse, you become the person in your life, and everyone else in your family's reference for palliative care. So if there is someone who is dying in your life, in your extended family, something, you become that person, and the boundary of how involved you are in that is very blurry and difficult to navigate because you don't have all the information. And I guess, have you got any thoughts about that? Because that in itself is a boundary navigating exercise. Jess or Holly, there's no pre-prepared questions for that one. So that's
I can speak to that quite easily. Yeah. I have a family member who has a terminal diagnosis, and I do get the questions about, the opioid rotations, making sure that the bath adds up, and early days especially, it was getting some information and sort of comments like, well, we won't need community palliative care because we've got you, and being very clear that I don't have the information from the hospitals. They don't share it with me. They share it with your community palliative care team. I'm here for you. I am here. I'm here as your relative, but your community palliative care team provides different, they provide the clinical care, and it's really important because they have a lot more information than I do that I can't get and I don't want to get. I want to be your relative. So it can be tricky, but important to make sure that people are going down the right track. And we have a lot of questions about, navigating when somebody it comes into whatever service you're working for. Yeah. Really tricky, really, really tricky. And, I've worked in the community space where it's probably a little bit easier to avoid going for home visits and to make sure that you're adhering to your policy around privacy and not accessing notes, which we all do. And the work I work in now in consults, we can navigate that a little bit more easily by sending people to other sites or other patients. In inpatient ward or in a small community, that would be a lot more tricky. So, Holly is probably the best person to talk to about that.
Have you got any thoughts about how you navigate that aspect of boundaries being a palliative
I'm not
care
great. I'm going to be honest with you.
No, it's really hard. It's really
I think there's two parts. Like, I haven't had anyone in my immediate family, but I've had a lot of friends, and I'm of the age now where people's parents are dying, and I've helped to palliate a lot of my friends' parents in the last probably 5 to 10 years. And I've kind of always joked, in the country, we all barter our trades. The sparky does the job for the plumber, and the plumber does the job for the landscaper. And so often when my friends have said, no, that's fine, it'll come around, I'm like, it won't. I'm a palliative care nurse. I can't barter my trade. And so, sometimes the last few years, I'm like, actually, I can be of help. Obviously not bartering my trade, but it's like, I feel really lucky and fortunate. In a regional town, we don't have the services after hours that you do in Metro Melbourne. And so when I see friends that are caring for their loved ones at home and wanting to make that work, I have crossed that boundary and said, look, I'm not a relative. I don't want to read notes. But if you need someone to come and do that turn and wash with you, I'm there. If you need to call me at 2 a.m. because you don't know what the symptom is, I'm there for you. And I've done that. And I have actually taken time off work and said, you know what? I think we're looking at days. I'm just going to be around and I'll come over whenever you need that second person. And that has enabled them to stay in the venue of care they wanted. And for other people, it's just been about, can I help you navigate a really tricky system? Because if you're not health literate and you don't know, it's been not the physical hands-on, but it's been the going around there and spending the time to say, this is what inpatient is, this is what community can do, this is the reality of what you're going to get in that service, this is what death looks like, So I feel outside of my paid role, really privileged to be able to help my friends in that regard, but I haven't, probably if it was my closer inner circle, I'd be looking the same as Jess. I'd want to maintain my role. So the people that I've done that for, I don't have a direct role to the patient. It's more to, it's my friend's father, or it's a little bit more distant.
But I think it's about how you navigate that, because I think if you're going to do turns and roles, I think that's beautiful. I would do that for my relative any day of the week. Pad changes, whatever, I'm there for it. 100%. Because again, you've got the skills, you are, somebody that can provide assistance. But I'm not going to go changing any of the medication regime. So I think, again, if you know the boundaries between what's that therapeutic relationship and what is providing care in a way that, the family are doing at home as well. I would do exactly the same, Holly. I think that's a huge privilege.
I think too, the other part of this is that in that situation, that's where you being the kind of you're informed bystander who is watching a loved one die with very little information, or not even a loved one, a friend's loved one dying. You know they're dying, but they don't want to say anything, or they're not getting told all the information. There's distress in that as well, and I guess just there's a case for setting some boundaries around that too, right? Because actually there can be a lot of distress in watching a situation unfold that you can't control, or that actually you're not necessarily having much input in. Now, I am really sorry, because I'm just want to double check that when we may end up getting cut exactly on just checking with James. So we only have 3 minutes left, so we will be wrapping up there. Before we finish, two things. I just want Jess and Holly to succinctly say, if you were giving advice to new nurses or people working with new nurses, what to help them navigate boundaries, what would it be? Or to help foster boundaries? A take home.
You go, Jess.
Okay, cool. So I think for all nurses, not just new nurses, get good at your reflective practice. Appreciate that you are walking fine lines around boundaries every single moment of your working day. And we've just discovered even more areas that we're looking at our boundaries. So get good at your reflective practice, listen to what's going on for you, and then have somebody that you can talk to about it.
Great.
Yes, I agree with all of that. And the only thing I would add is practice those communication skills. If you think of it like the first family meeting you did, it's awkward and clunky and you're stressed. The same applies for boundary setting, but just have a go. It gets easier every time, and then it becomes a second language.
Yeah, thank you. So thank you, Jess, and thank you, Holly, for your time today, and thank you everyone for joining us. The recording will be made available on YouTube, and please fill out that survey, and you guys can let us know how that worked for you guys. And that is the end of the webinar by the looks of it. Have a lovely afternoon. Bye.
Thank you. Bye.